Hello and welcome to the Alexforbes Health Pulse of Healthcare podcast series. I'm Linda Kiston, a senior consultant at Alexforbes Health. Over the next few months, from July through to September, we'll be bringing you a series of conversations designed to unpack the complexities of South Africa's private healthcare landscape. As a healthcare consultancy, we see firsthand how dynamic the healthcare system is and how it is coming under increasing pressure from rising costs, affordability challenges, and changing member needs. As the largest and most established healthcare consultancy in South Africa, Alexforbes Health works closely with employers, medical schemes, and members every day. This gives us a unique perspective on the changes shaping the healthcare landscape. Through this series, our aim is simple: to help you better understand how the healthcare system works, the changes it faces, and importantly, the role each of us plays in building a more sustainable private healthcare sector. So let's get started with today's episode. We're tackling a question that many South Africans are asking. Why do medical scheme contributions keep rising faster than inflation? Joining me in unpacking this is Nicole Lombard, Principal Consultant from Alexforbes Health. Nicole, welcome.
Thank you, Linda. It is really great to be here. And you're absolutely right. That is definitely one of the most important and common questions that we are seeing right now.
Let's start with the big picture before we get into detail. What are the main drivers behind these rising contributions?
That's really a great place to start because there isn't just one single factor that contributes to the rise in contributions. Medical inflation is actually made up out of four broad components. Firstly, there's your provider tariffs. Now, these generally are linked to inflation. But then secondly, you have utilization. And this is really driven by the demand for services within the membership base. And it's very closely correlated with the age of that specific membership base. Thirdly, and as you would imagine, new technologies, new services and treatments and new medications that are flooding the market right now is very expensive, especially when they are first introduced into the market. And lastly is your medical schemes risk mitigation strategies. These really are the initiatives that the scheme takes to control the cost of delivering the healthcare and benefits within their membership base.
So it's not just one issue, it's multiple factors.
Absolutely. And it's actually a combination of the first three components that really drive the contribution increases above inflation.
Let's unpack that further. Where is most of this money going?
Your main cost drivers remain your hospitals and your specialists. Hospitals make up about 35% of the total healthcare spent within a medical scheme, and specialists make up a further 28%.
So that's a significant portion.
Yeah, roughly 63% of the total expenditure of a medical aid scheme. But what really is more important and interesting is that it is not the number of members going into hospital that is driving up the cost. It's actually the complexity of the care. You see, patients today are living longer. They are managing multiple chronic conditions, which actually present as more serious health conditions later in life. And when these members eventually enter the system, they require more tests, they require more specialized and costly care, and they actually stay in hospital longer.
So it's not just volume, it's complexity.
Exactly, Linda. And on the specialist side, the costs are even rising faster. This really is driven by the demand for healthcare, especially after COVID, a growing and aging population, and really the fact that specialist fees are not regulated in South Africa. There's no single fee structure for specialists, so it really boils down to supply and demand, and specialists hold significant power over the pricing.
And I imagine expectation from members are also changing.
Absolutely. Members today expect healthcare to be faster, more convenient, and more personalized. So things like virtual consultations, your digital platforms, and tailor-made care programs are really becoming very standard expectations.
Which are all positive.
Yes, they improve the access to healthcare, they improve member experience, but they come at a cost, especially in the short term when the technological development needs to take place. But more importantly, the longer term effect is that because healthcare is now so easily accessible, we do see an increase in utilizations and members are actually utilizing their benefits more frequently.
So we've got rising costs and increasing demands, but you also mentioned demographics as a key factor. How does this fit into the picture?
So Linda, all of the cost pressures that we have mentioned this far actually get amplified right here. What we are seeing is that medical schemes are aging. Over the last 20 years, the proportion of members over the age of 50 has risen significantly. Together with that, fewer young members are actually entering the system. So we have seen that medical schemes have aged by approximately 5 years over this time period. Our actuaries actually tell us that for every 1 year that a medical scheme increases, you can expect the claims to rise by 2%.
And why aren't our younger members joining the scheme?
I think there's various reasons. The unemployment rate among the youth is quite high. Medical scheme contributions are very expensive. That places added financial pressure on the youth. And to be quite frank, it's not compulsory for the formerly employed to belong to medical schemes. So younger people feel that they don't need medical aid cover right now, so they put it off until later in life when their health starts deteriorating.
So why does this matter?
Because medical schemes rely heavily on cross-subsidization. The younger, healthier members who have less claims often offset the cost for the older members who tend to have more claims. So as fewer young members enter the system, the balance actually shifts.
So the pool becomes older and more expensive.
Absolutely. Older members tend to have more chronic conditions, they use the healthcare system more frequently, and their treatment is more complex and more costly.
So let's talk about how members are responding to all of this.
Well, what we are seeing is a very clear trend to what we call the member buy-down behavior. Members are choosing to resign from the more comprehensive type plans and consider more affordable plans like your saver plans, your hospital plans, and your network-based plans.
So members are actually trying to manage their costs.
Definitely. We are even seeing a trend where members are splitting their cover, where they are choosing to take a hospital plan within the medical scheme and then top that up with a medical insurance product to cover their primary health care and certain other day-to-day expenses.
Okay, so that sounds like a very practical solution.
Yes, it's great for the individual, but it starts to cause structural problems within the medical scheme. You see, they are now losing out on higher contributions and on that cross-subsidization. They still expected to pay the hospitalization costs, which, as I mentioned earlier, is probably one of the biggest drivers in their expenditure. And let's be honest, it is the older, more higher risk members that remain on the medical scheme, because your younger members are the ones that will often explore these other solutions.
What does this then mean for the financial health of the scheme?
Well, we're already seeing some of the pressures come through. If you look at the claim ratios, these are extremely high at the moment. Majority of medical schemes are tracking close to 100%, while some schemes are even over 100%.
Meaning?
Medical schemes are paying out almost everything that they collect in contributions to cover the claims. And bearing in mind, you still need to cover the cost of running the scheme, as well as the solvency requirement that states that a medical scheme needs 25% in their reserve account. So you can see there's a very small buffer for a medical scheme if they are paying out 100% of their contributions towards claims. So as the average age increases, the claims go up, and medical schemes simply need to raise their contribution to cover these increased claims to remain sustainable in the long run.
And where does regulation fit into all of this?
Regulation plays a very significant role in the cost of healthcare and the environment in which the medical schemes operate in. Probably one of the biggest driving factors is prescribed minimum benefits, what we typically call PMBs. These are a predefined set of conditions that every medical scheme has to cover at cost across the entire product range.
So that applies to everyone across all options?
That's right. It's supposed to give a level of protection to members, but it comes at a significant cost to the medical scheme. PMBs make up a large portion of the medical scheme's overall claims. It's estimated that medical schemes pay on average about R1,000 per member per month to cover the prescribed minimum benefits.
And that has an impact on affordability.
Yes, definitely. Because all of the plans need to cover this minimum level, your lower level plans that are aimed at providing affordable cover actually becomes expensive for your low cost earners and your young individuals to join.
There's been a discussion around reviewing PMBs. Where are we with this?
The PMB reform discussion has actually been on the cards for many years, and the intention is to move away from the hospital-centric model and to create a more primary healthcare-based model focusing on preventative care. So things like GP visits and preventative screening and testing would be included in the prescribed minimum benefit package, really with the aim of ensuring that diseases are detected early to prevent the more costly hospital admissions later on.
That sounds more like a more preventative approach.
Yes, and it actually aligns with a broader healthcare reform in South Africa at the moment.
And what about low-cost options? Where are we on this?
Your low-cost benefit options, typically referred to as LCBOs, have also been in discussions for many years. And again, these options focus on providing a package of benefits that will focus primarily on primary health care and preventative care.
And then there's NHI, which adds another layer.
Yes, Linda, the buzzword NHI. So the National Health Insurance Framework actually states that medical schemes will play a top-up role once NHI is implemented. So they will cover services that are not included in the benefit package under NHI. At this stage, it is not very clear what exactly will be covered as part of this benefit package. And then there's also the legal challenges, which is placing additional uncertainty as to when NHI will actually be implemented.
So still quite a lot of uncertainty.
Exactly, and all this uncertainty around prescribed minimum benefit, low-cost benefit options, and NHI is actually preventing medical schemes from coming up with innovative, more affordable solutions for their members.
So let's bring it all together. If we had to summarize, why are medical scheme contributions higher than inflation?
Linda, if I had to summarize, I will bring it down to 5 key driving factors. Medical inflation is higher than CPI. Rising healthcare costs, especially your hospitals and specialists, are increasing. This is driven primarily by increased demand and utilization and care that is becoming more complex. The membership base within the medical schemes are aging, and the member behavior is changing, which is really impacting that cross-subsidization.
Thank you, Nicole. This really helps us connect the dots. It has truly been insightful.
It's been a pleasure, Linda.
And thank you to our listeners for joining us. We hope this conversation has helped you better understand what's driving healthcare costs and why it matters. Join us for our next podcast, where we'll be digging deeper into the primary healthcare insurance products versus low cost benefit options. Until next time, take care.